Hello, everyone. I'm Ron Rolfing, your host of the ACAP Preferred Vendor Education Series, and I'd like to welcome you to our latest session presented by ACAP Strategic Ally HealthEdge. Our presenters today are Jennie Giuliany, lead clinician and client management with HealthEdge, Christine Messersmith, CMO of Denver Health Medical Plan, Norine Howard, senior digital adoption partner with Wellframe. And they will be presenting the session, Next Generation Care Management, how Denver Health is leveraging digital investment for member-centric engagement. Before I turn it over, I do have a few housekeeping items I need to take care of. This call, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's webinar, and we will post a slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. You can also post a note, an RFI, or even an RFP on the preferred vendor connection portal. And of course, during today's call, you can ask a question at any time by clicking the Q&A icon in your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'll pass it over to our presenters.
Thank you, Ron. Hi, everybody. Welcome to today's session. I'm Norine with HealthEdge's Wellframe solution, and I'm here with Jennie Giuliany on HealthEdge's Guiding Care solution, and Dr. Christine Messersmith, CMO of Denver Health Medical Plan and Guiding Care client. So like I said, my name is Norine Howard. I am a nurse by trade for over 27 years. Throughout that time, I've worked in various levels of the healthcare system, but most recently, and probably most relevant to this call, I was a care manager with the local health plan in Nebraska. And I was the director of that care management department where we implemented the Wellframe care management tool. I got to see firsthand how implementing a digital tool can help to transform a care management program. And I also got to see how it improved member outcomes. And I've been at Wellframe now for about 4 months, helping clients do the same thing. Jennie, would you like to introduce yourself quick as well?
Sure. So my name is Jennie Giuliany, and I'm also a nurse, and I have been with HealthEdge or Guiding Care for over 12 years now. And prior to that, came from another client site in which we had implemented Guiding Care, and overall been in the managed care world for quite a while, even prior to going to nursing. And so have really enjoyed working with health plans and with members and helping to coordinate that whole member care using digital solutions.
And Dr. Messersmith?
Sure. Good afternoon, good morning, good morning, good evening, and good night, I think is the saying, depending on where you are at. My name is Christine Messersmith, and though I don't normally hyphen my name, I got married about a year ago to my high school sweetheart. So most people call me Dr. M because it's just too complicated a name. I'm a family medicine physician, and I've been in private practice for over 20 years. Along in that journey, then this was in Oregon, in a small town, Roseburg, Oregon. Along the journey, the state expanded Medicaid through the ACO, Medicaid expansion, and we developed CCOs. Being based familiar with an ACO called a CCO in the state of Oregon. And as many times happens to physicians in the setting of administrative tasks, everybody else steps back, says they don't want to perform them, and I just was left standing. So I got involved in administrative medicine because not very many physicians in the area were interested. That said, I've been involved in administrative tasks for over 15 years with Medicaid, Medicare, behavioral health organizations in Oregon. And for the past 3 years, I've been the Chief Medical Officer at Denver Health Medical Plan.
Wonderful.
Thank you, Norine.
Thank you. So today, Jennie and I will speak with Dr. Messersmith, and I will refer to you as Christine through the rest of this, so I don't butcher your name at all. And we want to understand Denver Health Medical Plan's experience specifically with your Medicaid population, where we will address the challenge working toward the next generation care management, particularly within the nonprofit publicly funded health plan, and talk about what you are prioritizing for 2023 and beyond. I think the insights from this large safety net healthcare payer will help payers and systems of all sizes think about the challenges and opportunities to improve member engagement within their own health ecosystems. So Christine, why don't we start with a little bit of an overview of Denver Health Medical Plan?
Sure. Denver Health Medical Plan is a subsidiary of Denver Health Hospital Authority. Denver Health Medical Plan holds a contract for Medicaid, and we'll go into some of the features of our membership. The important part is that we're a safety net hospital and a provider-owned plan. So you think of IPAs or other situations in which providers own plans. It's really important to understand the integrated mechanisms of delivery, the opportunities that arise because we are a provider and a payer, and safety net, which is and in an urban setting, downtown Denver, where the majority of our members are living in a very tight-knit environment.
So key characteristics maybe about the population would be helpful.
Yeah, sure. First and foremost, we're a moderate or medium-sized plan, maybe on the smaller side with 130,000 lives. The majority of those lives are Medicaid, around 110,000 Medicaid lives. We have an MA, both DSNP and a routine MA plan. We have a commercial line and then self-insured because we are a large organization. We have a self-insured product for our employees and their families, and a public market option. We're on the exchange as well. We're growing our DSNP and exchange populations, and it's a very unique environment in which these individuals have very high rates of chronic disease. For example, if you are already going to Denver Health, we have a very robust HIV program. So if you're participating in the HIV program at Denver Health, of course, you would select our exchange product. Similarly, we are a trauma center. So we have a lot of trauma that comes down into the area. As you can guess, with the Medicaid population, we have a high rate of depression, anxiety, substance use, a lot of comorbid conditions, lots of social determinative health issues. Homelessness is a high priority and impacts the health of our members. So it is a typical Medicaid diverse population. Add on to it the urban setting challenges.
With that complex of a population, what are some ways in which you at Denver Health have worked with those different care management programs to address that whole cohort, that whole group of members that, again, they're running the gamut from complexity and different programs?
Sure, it's a really good question. One of the advantages of being part of a safety net hospital or delivery system is that we can communicate, collaborate, and coordinate care. So, and we'll talk a little bit more later about why we got involved the way we did, but just to be clear, we've had to develop a lot of care management type programs, and we're trying to optimize the tools that we use. So coordination of care would be the number one way in which or the number one focus. And then that complex case management or case management, you can call it anything you want, but it's engaging with the member to ensure that they get the care they need in the right place, the right time, at the right moment, and that we're paying for that service with the right contract.
When we're talking about all of these different programs, and we know that this really resonates with a lot of our plans and how we're doing care management. Care management's not new, but the requirements that plans are now under based on regulatory requirements that are coming out, STAR measures that are then taking into consideration member satisfaction with all of these care management programs. What are some of those things which you guys have worked on because of this complexity, being able to encourage or engage the members in these different types of programs as well? And what types of populations are you really supporting with those different programs?
Yeah, it's a really good question. And that is ever changing. What I would tell you is, I'm going to tell you a little bit about my philosophy around safety third, and I'll throw it in right here. I don't know if anybody's ever heard that safety is first. Well, we don't run with that philosophy in our household. We call safety third. And there's a reason for that. If safety were first, you would never get out of your house. You wouldn't leave the door, right? So safety can't be first. Safety is third. Well, what's first? Fun and adventure. I'm going to say that we have this philosophy that regulations are third. We have to meet regulatory requirements. We don't stay in business. So in that sense, it's first, and you need to meet those regulatory needs. But following along with this safety third philosophy, regulatory requirements are third in that motivation, engagement, member provider satisfaction. Those are the things that are first if we really want to make a difference. So I'm going to say that regulations are fundamental and a requirement, but we're transitioning from building this foundation to trying to actually make a difference. So the individuals we're trying to focus on are those that we can make a difference in. How do I know who I can make a difference in? I need better data, better technology. How do I engage them? I need to understand that population and the tools they're using, better technology and better options. So it's kind of it's a full circle, but it is the wave of the future and where we're moving to. So our members are complex. I need to focus on the right members at the right time. And it's a journey. It's an ongoing challenge.
Absolutely. So I would agree. It's increasingly important. As a former care manager and having health plan experience myself, and having some experience trying to support members with complex and health and social challenges, like you're seeing in the Denver health population. One of the things we love to see is bringing these insights to support payer clients as they implement and optimize new tools and solutions for the ongoing management and goals. We love to talk about Denver Health Medical Plan's experience in these areas.
Sure. This is a fun story to talk through, right? Digital transformation, what does it mean? It is a journey, but I am old enough to have participated in some pretty key points in that journey. Let me just start with giving you a picture of what life was like in the olden days, as my daughter would say, when I was sitting in the room with a patient and I have a chart in my hands and I remember the actual day. It's one of those charts that's, 2 or 3 inches thick, and you have these metal prongs that would hold the paper together, and you're sitting on the sliding chair and the patient's in front of you. And I've got that chart open, propped on my lap, and I'm searching for an MRI. Remember those days? You're searching for the result for an MRI that I've ordered, and I need to find that. And I'm lifting up the papers to search through the section that we put x-rays and radiology in, and the metal clips break. And the papers fly across the floor. And I have this patient's chart scattered across the floor in front of me. This was about 2015, Jenny, just about 6 months to a year after we started a universal or UMQA1 chart in our community, funded by the IPA. That was the day I made the decision to move on to an electronic health record. Community offered electronic health record. It's clear in my mind because it was torture and torment. Mm-hmm. When we moved to the EMR, it did not do everything that was promised. We were promised that life would be easier. We were promised that we would make more money, see more patients. None of those things came to fruition. So then what was the advantage? Why wouldn't I go back? I mean, if you ask me today, would I ever go back to paper? Right? I would never go back to a world in which I can't find the MRI. I would never go back into a world in which I don't get to see all this information. So the way I look at this is the digital transformation is much like moving from a horse to a horse and buggy, to a train, to my car. It's not that it's easier. It doesn't cost me less, to be clear. I don't spend less time in it. This is, what is it, 25 miles in a day a horse can get you, and I'll travel across country. Don't spend less time doing it, but I get a lot further, and the expectation is more. And clearly I can fly from here to Malawi, which is where I'm going next week. You know, I can take advantage of that technical transformation or digital transformation. So I see it the same here. The expectation isn't that my life is easier. The expectation isn't that I'm not spending money on it. The expectation is that we're doing a better job and that I have more access to more information and I make the right decisions. There have been bumps in the road, right? Anybody who's been in an EMR knows that it's TMI, too much information, maybe they don't have the right information. There's a lot of challenges there, but the vision is real. And I do expect that this is an ongoing journey. We are a Medicaid primary organization. We're not markedly digitally mature. So we have a ton of opportunities to improve what we do, to use data and technology to make better decisions and to engage with our members in a new and different way. So I love this position, right? Because I know that anything I do is going to move us forward. Lots of opportunity.
And at the end of the day, truly, when we're talking about care management, we are still clinicians. We're still wanting to help our members. We're wanting to make sure that they're doing well. We want them to be happy and be satisfied. And we also get satisfied by making sure that we're helping these members. So we know that digital isn't always easier, as you said. It does take that learning curve, but it does put so much more in your hands. And at the same time, again, we're trying to get to that point where we're all happy and we're all doing what's best for the member, and the member is satisfied and happy with us.
Yeah, it goes back to that safety third. What does really make a difference is member engagement. We understand that the member is part of their outcome. So if the world is moving forward, we have to move with it.
Yeah. That brings us to our next question. So care management has really shifted, I think, in terms of possibilities, supporting members, in terms of opportunities for outcomes. And a lot of this transformation is being fueled by the new digital tools and solutions. The care management literature describes these high-level outcomes associated with platform implementation. So with your very high complex patients, where do you really see the most value with these solutions?
I love that question because it's a tiered answer, right? Back to our philosophy around safety third, adherence to regulatory requirements may be third but required, and we can't stay in business if we don't. So one of the values any tool brings to us is ensuring that we're meeting those regulatory requirements with the path of least resistance, right? So it's embedded in the product and I'm not having to think about it. So take that off my table. I don't want to have to think about how I'm going to meet that. I want to just do it for me. It's not entirely possible, but we get there. And then I really want to be able to focus on that interaction. Number 3 on this slide, I think is really important to understand. We'd like to leverage our tools to help us optimize our social determinants of health and health equity. I can't get that anywhere else. I'm not finding the data where I need it. Claims-based data doesn't give me what I need. So our intent is to use the care management type tools to document, augment information we get from other sources, look at the data from a different direction and find different ways to intervene. So all of those things support the quadruple aim, by the way. So I'm a big believer in the quadruple aim of the member experience, cost and outcomes. That was the triple aim, adding on to that, the provider experience or health equity, which would then make it 5, what is it, quintuple? Anyway, provider experience or health equity are how some view that quadruple aim, and I like to put those both together. So all of these strategies are really to support that quadruple aim, which is a well-rounded strategy with that foundational approach of regulatory requirements, and then really just expanding, opening our minds to how we actually approach interventions for the social determinants of health and then managing health equity.
And so much of this, again, being driven based on these regulatory requirements are becoming more and more around electronic. it's not so much anymore that you can prove it on paper and you can't supply the information to members on paper as much anymore. There's really a push for everything to become electronic, including gaps in care being electronic data sets in which you're being able to shift and move these items, as well as when we get down to communications being more and more electronic versus the traditional method that we're used to. So it is really, this is the day and age we're talking about. How do we take this forward with these new tools?
Yeah, they have to and want to often align. You have to, it's a regulatory requirement. And then I want to do it in a way that's meaningful. You used to talk about meaningful versus meaningful use. I need to meet all the marks for meaningful use, and then I want it to be meaningful. It's similar here. They are aligning more and more.
Yeah, I would agree with both of you. I had a CMO that used to say, it's all about where the rubber meets the road, right? And I think where we're at in this presentation right here, it's talking about how the next generation care management tools actually helped a Denver Health medical plan care manager support an actual Medicaid member is really where, you know, the gold is, where it matters.
Yeah, we have a lot of stories to tell. And, you know, I was thinking through what's the most pertinent to share. So I have a story I want to share. And on occasion, we think through the touchy-feely side of this. I'm a physician. There's a huge touchy-feely side. This is what I just said. I mean, number one is fun and adventure. Number one is making a difference in the world and impacting our members. But there's where the rubber meets the road side of this is, what does that look like on the backside? So the story I want to share is about a 36-year-old male, CVA, must have a ton of social determinant of health issues, but I'm not going to go down that path, right, to have a CVA at a young age. But the individual member is in a inpatient rehab facility, and an auth request comes in for a home health facility. It's not an on-site facility, but an in-home health request for a specialized rehab in the home. They're out of network, so they're not contracted with us, and gonna guess that they're not providing traditional type services. They're not somebody I'm familiar with. What happens next? Of course, the team puts together the request. The request comes to me, and I say, it's out of network. We have a ton of in-network home health options. Consider an in-network option. So what happens differently because of the way my team is structured? So the team is in a system called Guiding Care. They have a module. The CM team or care management team is in a system called Guiding Care, and they have a CM module. And guess what? They can see each other's notes. So rather than just let Dr. M say, oh no, this is out of network, we're going to deny for out of network, the team communicates with the CM team and asks the questions. Well, why is it we were requesting this out of network? How hard did they try to get home health in network? What's the real value to this member? What's going to happen if we don't do this? And they come back to me. I give them tons of kudos and some for doing so, because this is what I trained them to do, and they did it. Jenny, you would be proud. They come back and they say, okay, Dr. M, I know you were thinking this was just out of network, but based on what the care manager has said, based on their interaction with either the discharge care manager at the facility and the member, we believe this is an important service for this member for the following reasons. They went even a step further. If for some reason this particular outside entity is not willing to contract with us for our rates, which can happen, we now have some options and alternatives that are not contracted as well, but that are willing to. So not only did they come back to me with a reason that we need to move forward with this option, they created alternatives. That, I think, is the magical side, or the hidden side that nobody wants to see, but is magic. Member hopefully never hears about any of this, doesn't know what we're doing, and in the end gets a service they really needed and doesn't get readmitted to the hospital.
Wow.
And I think the beauty of this also ties into how the left hand knows what the right hand is doing. There's not the siloed effect of using multiple different systems. You're coordinating it all between the one system, and you're really taking care of that whole member. And that should be where we all want to strive to be, where we're all working together. And I think it's so powerful when you're sharing one system to be able to coordinate that around them.
Yeah, it doesn't always work as smoothly. We've worked hard to ensure that it does, and we needed to ensure that our platform and our tools were set up in a way that would make it easy to do so.
Right. Yeah. I think by having those workflows and working diligently with staff, and I mean, I just love that, because that puts it the member in the center of it, and the care managers know exactly what's happening as well too. So great example.
Yeah, my favorite part of the story is that they challenged me on it and they were right.
That takes me back. I used to do a little of that. So go ahead, Jenny. I think you had some comments on this one.
Oh, I was just wanting to see how this is really driving you forward. What is it that you are looking at Denver Health for your future goals and moving forward with the resources and your digital tools that you have?
Yeah, great question. We're going to go back in time a little bit. I think we'll go to the next slide. So I shared with you that I've been at Denver Health Medical Plan for 3 years, and I have an extensive history in a rationed healthcare state with Medicaid and Medicare and in a behavioral health environment. But I started I was familiar with guiding care in Oregon. I'll back up a little, Jenny. It turns out I knew Jenny in Roseburg. I started as a green associate medical director, and Jenny taught me about QI. She's the nurse that slapped my hand to tell me what I could do and not do. So I learned a lot from Jenny. Well, guiding care started in Roseburg as well. We had their grievances and appeals module, and they stole Jenny off to actually help make their module work better, and she's been a valuable asset. When I came to Colorado and was looking for opportunities here to try to transition, because I had the love of my life living here in Colorado and I was in Oregon, I was exploring opportunities, and I went to consult with Denver Health Medical Plan. They'd had 5 medical directors in the past 5 years. I came into an environment in which they were outsourcing their care management in UM. And because of some changes in contracting, they were re-insourcing those services. So I walked into an environment in which we're bringing UM and CM back in-house. We have a ton of contracted staff doing the work, and we don't know where we want to head next. So first and foremost, you have to assess what you have and what you need. So in our environmental scan, we discovered we're using guiding care's tools, but hadn't upgraded them for years because they were going to outsource, hadn't been optimizing them, didn't really understand how the tools worked, hadn't spent time and effort. So what we did is, first, understand what you have. Secondly, ask for help. So we come back to guiding care and say, what do we need to do in order to use your tools appropriately? That requires some upgrading, which we've done several levels of upgrading and are finalizing those this next year. It required building of relationships, understand the tools you have in front of you so that you know what to ask for and that you know what you can do yourself. Huge, we can give a whole speech on what that looks like. My teams didn't know the tools, they were all new. If you ask them today, they will tell you they understand the tools, they understand what they can do for themselves, they understand what they need to ask for to have done with guiding care, they understand how to make minor changes so that they're not reliant, and they have a much better sense of it. I think of it like a smartphone, right? You get your new smartphone and then you understand your tool. So there was one last part about that. So let me come back to this. So we did an environmental assessment. We upgraded our tools. We collaborated with our software partner to ensure that we were driving the system. And last but not least, a part of that was doing some ride-alongs or some tag-alongs, ride-alongs, where we invite that software vendor into our world and say, help us understand this, go side by side. Help us figure out where our gaps are, what we don't get, what we do get, and where we need to head. That was one of the most pivotal components of our progress.
One of the things that we've been doing quite a lot of, even more recently, we've done the ride-alongs with Denver Health. We do them with our other clients as well. And it is something that we love doing. It is our clinical teams, it's our product teams that come, and we do sit side by side, whether it's virtually or in person. And there's so much to be learned, not just from our clients, but for us as the vendor as well. Where are things that we can help to improve this so that you do get better one-on-one time with your members, making some of the transitions in the product so that it does make it easier where you can focus on that member more, but at the same time being able to help with where are those best practices, what are those things that you can do to leverage those tools. It's exciting, it's fascinating, and we just love partnering too. And so we really enjoyed it.
Yeah, I would say there's always a bottom line in this, and that is you have to own, in order to optimize what you have to own it. So it means we really had to step up and say, we have to understand this product. And what we asked for is some help in doing so. I think it's going to fail anytime any customer in this setting, where the customer, no matter what the tool is, if the customer doesn't understand the product, whatever implementation, upgrade, or utilization is going to fail. So that would be my number one thing that I'd say we always have to own that piece.
Yeah, I love that you talked about that, because I think a lot of times, even at the beginning, there's an embracing of it, I think, but there's a lot of change management that has to happen, and change management is very difficult. And if it doesn't continue and it's continuous with, upgrades and things that are happening, a lot of times there's opportunity that is left behind, and a lot of potential can go untapped, which we see very often. And so sometimes, like Jenny, you were talking about, those ride-alongs or those reassessments are so valuable, because very often there can be staffing changes or structure changes within the teams and workflow changes that we can help adopt, help with. So I love that you were able to do that.
Yeah, I like to call them tune-ups. I'm not sure that everybody else does, but
that's a great, I love that. That's fantastic. So on, Christine, I think on this slide, you were going to talk to us about another priority you have going on with engagement.
Sure. And I think it's embedded in some of the conversation throughout the process. But to be clear, we know our members are sick. I don't think I need to convince anybody of that. We know that engagement helps to drive improvement in outcomes. I think everybody believes that and knows it. I don't know that we spend much time on that. What we struggle with in the Medicaid world is a belief that our members don't have access to technology.
Yeah.
And there's some truth in that, right? In the past, we certainly didn't have their phone numbers. Many of my members in Oregon didn't have Wi-Fi. Many at the time in Oregon didn't have cell phones. But with COVID, and probably prior to COVID, and we're just underestimating, but certainly in the past 2 years, we have new evidence that really does support the fact that the majority of our Medicaid members have access to some sort of technology, usually a smartphone, maybe it's prepaid. There may be some limitations, but they really do. So one of our goals is to understand the current needs of our members. And if Medicaid members have access to technology that we underestimated, we want to use that or optimize it to engage them. And clearly, the world is changing. COVID was a springboard for many things around telemedicine. I can foresee many ways in which we'll continue to change. We as the payer have to change with it. And we've tended to lag behind in the Medicaid world for good reason. Our members aren't driving that particular focus, but we need to use it. So it's being open-minded, agile, and understanding how to engage our members in different ways. And I believe our using some AI tools and technology will get a better sense of what works for our members, so it's much more individualized. The Netflix concept, where you have these individualized ways in which you interact with members, it is our goal. So it's changed our drive. And it's that thing I keep saying around safety third and regulations third.
Mm-hmm.
I have to meet those regulations, but to make a difference, I really need to go to that next step. How am I going to engage and enchant my members and make things easy for my providers? So the other thing I would say is I want simple solutions. I want things to appear simple in the end to every one of my members.
Yeah, I think I love the enchant and the simple. and easy. That seems to work well with members. And we had a saying at the plan that meeting members where they are, and where they are is where their cell phone is. And I don't think that excludes any of the population at this point in the game right now. So I love how you think about that. And I would only add that it seems to be too that engagement metrics are becoming really important for CMS and NCQA accreditation and STARS ratings and things like that too. So however you're able to capture some of those metrics is ideal as well.
Yeah, absolutely. And I think we talk about that a little bit more in the next slide as well, is that ongoing conversation about how do you take advantage of, I want to get credit for everything we do and I want it to work. So I'm choosing, selecting, and configuring tools that will track what we're doing so that we meet those regulatory requirements easier and easier and easier. So that's not the challenge. The challenge should be, how are you going to meet the regulatory requirement? The challenge should be, on meeting the regulatory requirement, how am I going to make a difference? Yes. So you're switching that priority and that utilization. So those are the tools we're looking for. We're looking for tools that allow us to do both.
Oh, yeah. So it's primarily that member engagement goal that led to you to reach out, I think, for the Wellframe digital engagement solution, to find out more about that. What prompted Denver Health to kind of want to explore that more in depth besides engagement?
Yeah, I was going to say, I think we've answered that question pretty well, but the next step is that integration. So the reason I'm looking at Wellframe over something else would be, how is it going to integrate with the tools I'm already using? So remember that quadruple aim and provider satisfaction. My care managers are providers. They're providing a service in that setting. And I need them to be able to engage with that member. So I need them not thinking about 5 different tools. So what I'm looking at is anything that can put it in front of the practitioner, everything within the EMR, or the practitioner in this setting, provider in this setting, need my care manager, everything within their EMR, which happens to be their care management tool. So integration, and keeping it simple for my team is the reason I would look to Wellframe, say, over something else that might not integrate.
I remember this was always something that you would use for us when we would be talking about what we want to do for our members or where we want to go. You would always say, if you had a magic wand, here's your magic wand. What would you do? No barriers here. Here's the magic wand. So in thinking of the sense, where would you see Denver Health with the magic wand going forward with this digital member engagement and being able to get to the members and meet the members where they are?
Yeah,
and I know we've a little bit already, but I want to dive a little deeper.
Yeah, and it's fun when it's turned on me, right? Magically, I want my care manager who's sitting in front of their computer, which of course that I can't get rid of. So magically I'd get rid of all the computers and it would just be right in their head. So I want an alert that tells my care manager the moment something happens that we believe is intervenable. Mm-hmm. The moment somebody doesn't fill a prescription and they're in my adherence panel and they have type 2 diabetes and they have had a heart attack and I have them on a statin, I want that to alert my nurse so that they can act on it. And that's probably that's a half a magic wand ask. I want to know what things make the biggest difference for that member in that intervention as well. So I want data around how we've interacted with them. I want the best way to communicate with them. I want the real-time data. And I want to know that intervention is something that will actually make a difference. So that's probably the simplest of examples, but I expand that to every scenario. I want to now, I want to know in a way that is useful, and I want to know how the best way is to intervene for you as an individual, which could go beyond how I communicate with you. It might go as deep as what things would make the biggest difference in your life, if I really wanted to get magical about it. It's a great question, and I
think that makes complete sense. One of the things when you were talking about that, I think you know, and Jenny and I have talked about this before too, in-person and phone communication isn't going away, right? We know that. And Christine, as you noted earlier, expectations are going up, and not just by members, but regulatory and everything else. Members, I think, and we've talked about this too through this call, members really expect omni-channel communication options. And the McKinsey model shows a lot of outcomes do rest upon next generation engagement methods. And it really just isn't, I guess, efficient to try to communicate in real time with all members to get information that can be captured digitally at their convenience. I mean, we had lots of examples of that in our care management department where people were back to work and working 8 to 5, and they needed to explain things to their care manager. And so they would use the digital tool to kind of answer questions about, you know, how their pain is doing or how nausea is, and answer surveys. And these insights would be elevated to the care manager so that they could update care plans or, you know, get them into their doctor sooner to avoid readmissions and things like that. So if they saw that the condition might be worsening. So I think it is interesting to kind of see how these life moments, you know, they're happening between calls and between clinic visits, and how digital can help with that magic wand you're talking about with elevating these insights.
Yeah, there's a huge mismatch between where we are and the expectations in the world, right? And it's one of the things I love about healthcare is because we're behind the times in healthcare as a whole, in particular in the Medicaid payer space. Yeah, we have so much opportunity. Small movements forward take us a large step. So I do love that. We don't have to be extremely innovative. We don't have to have the newest technology out there. We just need to move forward and have these options available. So it makes it a little easier to make those decisions. We are challenged with funding and bottom line, right? If you're in the Medicaid space, your margins are small. So it always has to be practical. It has to be implementable, cost effective, and efficient. So one of the good things about that is we tend to choose 1 or 2 things that does make a real difference. Mm-hmm. And I do like that particular perspective. We have so much opportunity. Any direction we move forward is a step forward. So.
Yeah, I always kind of likened it to if you can avoid, you know, an ER admission, or it almost, you know, when you think about the cost of those types of services, you know, preventing those types of things. So it does become something to kind of think about.
Absolutely. It's how you make a real difference.
Absolutely. So given these challenges, what are 1 or 2 of the next steps that Denver Health Medical Plan is considering towards the engagement goal that you have?
So good question. We're actually looking to a couple of things. One, we're working on some AI solutions to help us understand rising risk. So to focus and hone in on populations in an earlier phase. So it's a bit more preventive, but not disease preventive, rising risk preventive. And so coning and honing is the philosophy I would have. How do I cone down? How do I get an ROI? How do I make sure I'm targeting the right population in the right space? So that's one digital advancement that we're working through. And that can turn into things that are better insights and better alerts and better targeted interventions. And then on the other side of it, it's that communication and how we engage with the member. We need to augment our abilities. We are behind the times and know we have to, and are trying to figure out how to make the most use of the tools that are out there, which is one of the reasons that we've been looking at Wellframe and trying to understand how that might benefit us the most in that engagement.
And there's an element here too, as we're looking at all of these tools, where can you automate practices that are more administrative so that your clinicians can do what clinicians need to do and to help with this. And I think that's also one of those challenges that everybody is trying to work through as well. So being able to support that with some of your tools that you have at your fingertips is also something that's very interesting to a lot of people. What are the things that you guys are looking at for that?
Yeah, just like I think it's similar to the EMR transition. There's tons of data, right? We have all this data. We have access to lots of it. It's getting savvier about how you're using it, and ensuring that it's coming to the right person, the right place, and the right time is actually harder than you might think. We have HIE data, but turning that into a real-time alert at the moment you need it. We have claims data, right? That's kind of old news almost, But we have the HIE data coming in that are EDTs, that are ED utilization and discharges and admissions. We have other ways we've managed or coped over the years to get those, and now turning that into a real-time alert within the system the care manager works in, so that you don't have 20 steps before it gets to them, and so that they know about it at the moment that they can intervene. That's the magical the magical direction that we're working on right now. Each of these things is time and resource intensive. So you have to make a decision to prioritize one at a time. We can't just wipe a wand and it's all there. But that is the direction we're heading, and have taken steps to get there. And it is in partnership with Guiding Care. So we've spent time and effort to understand, where should that information go? What does it look like? Where does it make the most difference? Can we use it to close gaps in care? Can we, where do we actually take full advantage of it? Again, one step at a time. So it's not a fast moving process, but we can see that we can utilize the data better to achieve better outcomes, but also to meet some of our regulatory requirements and improve our revenue. And there's a bunch of other ways in which it can be useful to us. ECDS is another we want to use our care management tool for. Get the data into our care management tool, get it validated, get it out of it, and then we can use it towards HEDIS and our STARS.
Oh, fantastic. Yeah. Great way to integrate that together and get immediate value from both. So I love that. So we've covered a lot of challenges, a lot of progress. What you're thinking about as you look towards the future of care management at Denver Health Medical Plan, what are some of the key lessons that you'll be keeping in mind as you pursue 2023 priorities?
Number one is always the relationship. I'm going to come back to that again and again, which would have, if you'd asked me, I don't know, 15 years ago, I probably wouldn't have had the same answer. When you are partnering with a software entity or vendor, you have a customer vendor relationship, you need that partnership to work. So I need my teams to be able to get past any hurdles. I need them to be able to communicate. I need them to be able to get past the point finger, well, they didn't do it or we didn't do it. I need each of us to be able to own our parts. The product is only as good as we configured it. And we only configure it as good as we understand it. We only ask for things that we know we need. So I need that subject matter expertise partnership to function really well and not give up the second something doesn't work the way we expect. So persistence and partnership to understand that product so that we get out of it what we need, which takes me back to my good old example of my smartphone, right? It's either a phone I dial my family member on, or I can use it to accomplish a lot of different tasks. And it's kind of up to me whether or not I use it that way. So bottom line for me is pick that partnership well, understand your product, and push your team to understand it until they really feel confident and comfortable. They know how they can use it.
Those are great.
Call your vendor.
Call your vendor. Do a ride along, yeah.
We want you to succeed just as much as you want to succeed. So,
exactly.
Yeah.
Yeah, those are great. So I've really enjoyed the conversation today and love getting to see the real world outcomes with our payer clients. I know I've been doing the work a long time. I know Jennie has too. And the results, these results apply to the complex Medicaid population, improvements for patient with multiple and comorbid conditions. I know that from what I've seen just with customers and in, the experience that I've had, that we've seen a 33% reduction in hospital readmission for payers when they've configured certain care management programs, when they've, had certain workflows, worked diligently, had certain focuses, just like you said, utilizing, the programs the way they needed to, that type of thing. So there's certainly opportunity there. So I'm super excited to see what Denver Health Medical Plan achieves next with whatever you focus on upcoming. Jennie, I'll turn it to you.
Same. I think that this is, we're all so excited about seeing how all of these tools are going to come together as we've been working with the Wellframe and guiding care integrations, where we're really partnering in with that member engagement tool, along with the care management tools, along with your utilization management tools, all being in that one platform and tied together. You can really see how we can impact a member and be able to really coordinate all the way through those. And I think this is so exciting to get to this day and age where we're able to do that. And as you said, not be trying to flip through a huge 1,000-page chart with a bunch of just blank pages or data that we're going to lose track of, to be able to get to this day and age where it's going to surface. That I think is very exciting.
Thanks for that. We consider our care management team a differentiator for us. We believe it's valuable and important. We need to continue to invest in the tools our team uses and ensure that we're making it the path of least resistance, and that we can continue to engage our members as they progress in their digital journey. Appreciate that.
Do what they do best. Yeah. Well, I will see with Ron if we have some questions. I think this was the time for questions.
Yes, it is. Just to remind the attendees to click on the Q&A icon if they have any questions, and to type in. In the meantime, we do have some. Can you give us an example of some next generation reporting that your health plan was able to improve with the guiding care solution?
Was that next generation reporting? Is that what I heard?
Yes.
Oh, yeah. Well, I'll go back in time a little bit. I'll tell you, we went from a turnaround time for our utilization management where we were not compliant with from a regulatory perspective, to the point where we are now at 99.9% compliant. And the majority of that was in the reporting realm. So understanding how to extract an accurate universe that reflected our real world environment, so that we could make the appropriate changes in our workflows to meet that need, was one of the first things we did with guiding care. And I don't know if you remember this, Jennie, but it was probably the first few months we were taking the task on. So that was a huge accomplishment. Now that's 3 years ago. So I'll say some of the other reporting we're doing now. We're extracting data from guiding care and combining that with our claims data to try to understand our population a little bit better. We are using some AI and machine learning tools to try to cone and hone. There are quite a few other regulatory requirements that we're now meeting associated with our Medicaid contract. We use the grievances and appeals tool, so we extract reports from our grievances and appeals to report to the state, and are currently updating those so that we can meet the new state requirements for Medicaid product. On the care management side, we've spent a lot of time developing models for outcomes measurements and creating KPIs, some of which are regulatory and some are not. Some are just things we want to drive. We extract a lot of that data from guiding care from a reporting perspective. We do reporting straight from guiding care, and we also do quite a bit of combining of data from multiple different sources.
Okay. Yeah, our next question is for Christine. Can you recap your philosophy of how you stratify with prioritizing the member first and safety third, et cetera?
Sure.
I found this was very impactful.
Thanks for that. So we have a family philosophy of safety third, and it's an important philosophy. It's safety is not sixth or seventh or eighth. Okay, so safety is third, and that's because fun and adventure is first. You wouldn't get out of the house. You wouldn't do anything in life. You wouldn't make a difference if safety is first. Well, I decided we would apply that to regulatory requirements. So regulatory requirements are third, not sixth, seventh, or eighth. They're third. which means that the member and the provider experience are first. So prioritizing that member and their engagement, I think, is that fun and adventure piece. It's making a difference in the world. I don't think we make a difference unless we're focused on that member as first. And because I happen to be a provider, I'll put providers as second, because we're the key to getting to that member many of the times. So I think it's probably my way of supporting that quadruple aim. But I'm going to say regulatory requirements is third, and it's probably going to get me killed, because there are times that we absolutely have to meet those. But I don't want them to be my focus. I created that as the foundation. I have to meet them. They're must-haves, but they aren't how I change the world. They are not how I make a difference in healthcare. They're not how I make a difference in a member's life. They're not how I actually differentiate myself as a payer. and by the way, it is tattooed on me somewhere, just in case you're wondering. Safety third is really important to our family.
Okay, I believe you answered this while they were typing in the question. The next question, they did ask what is second, and you were you brought that up as being providers.
Yeah, I really think I'm aligning with that quadruple aim. I think you could put anything in there that you want, but it's things that are impactful, right? So it's just this internal thing I have to be in order to be alive. Safety's third because I have to stay alive. But really, why am I alive? So what difference do I really want to make with as a health system or as a payer? Number 1 and 2 are that difference I want to make in the world. It's a great question.
Well, it looks like that takes care of our questions for today. With that, I'd like to thank all the attendees for taking time out of their day to visit with us. I'd like to thank Jennie, Christine, and Norine for a very informative webinar today. Just a reminder that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks again, and stay safe.
Thank you.
Bye, thank you.